Thank you. And let me be clear about a couple of things there. I do half-time anesthesia, and by the pain service, Dr. Price means the chronic pain service. Today I'm going to talk about one part of the surgical ecosystem, and I don't intend to pick on just big pharma. I tend to talk about the larger system. And we'll be talking about some other nefarious terms like International Narcotics Control Board and some other things like that. So why are you here at a surgery conference and we're talking about medications? Well, drug prices, I think, have a lot to do with surgery, especially when we follow patients through their experience. You can see a list here of a number of things. Again, I'm preferential to a few of these points. Anesthesia drug prices in the recovery room, critical care, acute pain management, chronic pain management, and certainly palliative care. This came about through some discussions with our colleagues in Ghana. He said, why aren't you doing more regional here, when he came to visit us in the States? And I said, well, we don't know what the difference in cost is between regional and general anesthesia. So he said, well, let's look at this. And we saw isoflurane there, which is a common inhalational anesthetic that we use. They pay more than twice as much for the same bottle. We no longer have halothane available here, and they still do there. The economics and supply of demand of halothane have been complicated since it's no longer been available in the developed world. But you can see that it was the same price as isoflurane. So I said, well, Jabir, why don't you give me the other prices on some of the other commonly used drugs? And then I started to get really interested because the fentanyl pricing here, and this is the same unit, almost $8 versus 80 cents here in America. And the same for morphine if you look over on the far end, almost 4 times. Ketamine, interestingly, then I do believe they use more ketamine than we do. I don't know if this means that it's actually obeying the law of supply and demand. But ketamine is actually cheaper there. I think another important point is I looked at it the year after. And you want to talk about affordability, it's really hard if prices are going to change this much year over year. And halothane changed also. So I was really kind of confused by all this, and I'm going to take you on the journey with me as to where did I lead, or where did this lead to? And I think when we talk about the surgical ecosystem and the flow that patients actually experience, and when they talk about it, and they talk about their pain, or they talk about the good parts or the complications, this is part of what they go through. The acute pain afterwards, their recovery, sometimes persistent pain after surgery, and occasionally onto, well, I should say eventually onto palliative care. And patients can move back and forth around this, and they can actually move back and forth across it. So it's not a clear path. And I think these are parts of the ecosystem that we're interdependent on and with. A couple of these points have received significant attention over the last couple of years in the popular press. Acute pain and palliative care have had nice articles in The Economist. Palliative care, just within the last year, received a non-communicable disease palliative care endpoint through the WHO. And as imperfect as this is, milligrams of morphine consumed per cancer patient, there's certainly numbers of patients that satisfy or need palliative care that are not picked up by this. I think this is a big step in the right direction, though. This is recognizing millions, perhaps billions, when we look at it over time, of underserved and those suffering. I'm going to step back and frame the issue a little differently here when we look at traditional infectious diseases that have received a lot of press. And I think a lot of good work has gone into fighting AIDS and malaria. AIDS HIV started out as a universal problem, but the burden of disease has shifted towards the developing world. Now that's created interesting dynamics between governments and between NGOs, and ultimately had a good outcome in pressuring big pharma, if you will, to make life-saving treatments available to those in need, and at prices that were affordable. some ways, the number one killer in the developing world has not benefited from affecting all of us, perhaps. And the NGO and governmental response has not created the same response by Big Pharma. Now let's look at acute pain and palliative care. Acute pain is a universal problem. How it's approached is different here than it is, say, in Ghana. There's poor availability of pain medicines compared to here, and the translation of other techniques, because pain management is certainly more than just opioids, but that is a mainstay. Other techniques don't always translate very well. And this is an important jumping off point because the transition from acute pain to chronic pain is poorly understood and potentially very costly, both here and in the developing world. Palliative care is not only a universal problem, but a public health issue. And there's difficulties, even with the strides here in the developed world. How do we integrate palliative care into the continuum of care for our patients? That's not clear here, and it's not clear in most of the rest of the world. But what is clear is that both acute pain and palliative care, as their mainstay, need opioids. And there's a lot of controversies around opioids. We're going to start getting into this. Opioids create a lot of fear for a lot of people, but they are the gold standard for pain care. Let's go back to how did we get to the framework that we have right now for opioids? I didn't know any of this really before I started out on this talk. And the single convention, which I'll refer to as the single convention on narcotic drugs in 1961, with a couple of following amendments in the subsequent decades, really established the framework for how opioids are monitored throughout the world. Now, the key points in the quote I have here from the single convention, the board. It sounds kind of ominous. I'm going to make it even more ominous when we talk about the quasi-judicial International Narcotics Control Board. But that's what I'm referring to. And that's the body that is really in charge of this. Their view, I should say their role, is to limit the use, but at the same time ensure availability. Now, unfortunately, as you see, limit is the first verb there. And limit an adequate amount. I want you to remember these certain points because they're going to become salient as we go forward. So the International Narcotics Control Board is a small elected body from the UN that monitors country by country the opioids that are used, and those countries must report annually, and sometimes even more frequently, on their use and availability. Again, its role is to limit the access to appropriate roles. Almost the entire world has signed on, except for 8 states, so the de facto jurisdiction of the International Narcotics Control Board is implicit here. Every country must have a national competent authority. In America, that is a division of the DEA. And that division must report and predict for the next year, annually, on the amount of opioids consumed and to be consumed. In practice, it's really difficult to maintain the balance that was laid out there by the single convention. And this was brought up recently by experts at the UN and in a special letter, or a letter from the Special Rapporteur on torture in 2008. And I'm sorry for the wordy slides here, but I think this is important, that basically what's done here is comparing the lack across the world to not only opioids, but pain treatment, to torture. And so the bureaucracy that has been set up, most likely inadvertently, keeps appropriate care from being spread easily and effectively. And you see in the second part 3 of the main barriers: regulations, education, and attitudinal obstacles, which is, I think, a nice euphemism. So let's look at drug availability in low and middle income countries. We're going to talk about non-opioids. Oftentimes, not always, they're available at lower prices. There's a lot of reasons for this that my lack of economic background is not going to be able to explain it all. But oftentimes they're subsidized by the government or by the companies themselves, perhaps. Or it may be that the market forces or national health plans favor one versus another and are able to bargain for lower prices. Sometimes NGOs are able to subsidize or advocate. The role of Big Pharma, I think, is interesting. Certainly patents equals profits, and there's a clear need in the world of business to maintain and hold on to your patents because that equals money. Well, some would say that there's also a responsibility that comes with those patents. A responsibility that as long as you have the opportunity to make money off of the ingenuity, you must also work to provide access to medications. And I'm sure everyone here has memorized all of the Millennium Development Goals. Number 8, which is one that might be crossed over sometimes, talks about working in cooperation with pharmaceutical companies to ensure availability of essential drugs. All right, let's look at the opioid availability in the developing world. Oftentimes they are more expensive than in the developed world. You can see the median prices here are almost twice as much. Even within that cohort, there's a large variability in pricing. For a 30-day supply, look at the difference between India and Argentina. Now, the role of Big Pharma here is interesting also. Understandably, it's a business. The margin for immediate release morphine, which is the gold standard here, is very minimal. And so oftentimes, they're simply not involved. And at times when creative solutions do bring immediate release morphine to the market, it's often only there for a little bit of time. Because quickly, more costly extended release formations enter the marketplace and the immediate release forms are gone. And patients that a couple years before had opioids no longer do. Internationally, 80% of the world's population, 80%, has little to no access to pain medication. So why are they so different? Well, these barriers I talked about before. Let's delve in a little more. The single convention, as we mentioned earlier, is a broad outline. States are able to make their own individual laws, and oftentimes they do so in a more strict manner because of fear, because of a number of different reasons. So these laws need to be compared to each other, and we can figure out which ones work and which ones don't. Regulations are often placed not only on prescribers, but on procurement and pharmacists, between licensing, multiple licenses that may expire, and this can impede the availability of opioids. The stigma of opioids is, I think, where we can make a big difference through education. Education not only to our patients, to address fears of addiction, which are rare but present, and also fears of addiction and stigma from fellow providers. Education is, I think, one of our first places where we can break this cycle of undertreatment, which then creates low demand, or the perception of low demand. You can see here the global consumption of morphine across the world. You can see the line across the bottom of the global mean and how the vast majority of countries are well below it. Certainly those on the left of the screen tend to have higher human development indices. And that's one component that strongly correlates with the availability of opioids, but it doesn't have to be static. It doesn't mean that those with lower HDI and human development indices cannot move towards better opioid availability. Let's look at two countries here, Ghana on the top, the United States on the bottom, and on the x-axis is 1980 to just a few years ago. And then we have the consumption of morphine in milligrams per capita. You can see a couple of things that are important. I think the sporadic nature of the consumption that was reported in Ghana is quite drastic. Now, this is only morphine. This doesn't include some other opioids, but I can tell you that those numbers are more dismal. Certainly, the trend is also an important thing, and that this has corresponded with a difficult time, I would say, in America, and that we recognize that the opioids reflected here are not only used in acute and palliative care in America. I'm going to take the chronic pain issue off the table for the second, and we're only going to talk about opioids in acute and palliative care. I think what's also really important here is to look at these scales, and this is just staggering. Even back in 1980 on the American slide, this was more than tenfold than what it was in Ghana at any point. Let's look at how the complicated barriers here make opioids often practically unavailable. In Malawi, a physician can prescribe no more than a 3-day supply. 3 days. Doesn't matter where the patient's coming from, only 3 days. And in Malawi, only physicians may prescribe opioids. Well, there's one physician for every 100,000 patients. It makes it kind of hard to get to where you need to go and to get back and stay out of pain. If we're talking about a patient with pancreatic cancer, they're probably not going to get what they need. Look at India here, and India's actually made a lot of great strides over the last 10 to 15 years. But back in 1997, a simple change in legislation led to what I would say is a catastrophic change in the consumption of morphine. I think this last statistic is an interesting one. And when you're having trouble sleeping at night, you can go through the International Narcotic Control Board website and look at each country's individual opioids and what they predict to have for the next year and what they had for the last year. Well, in 2009, Burkina Faso said that they needed 49 milligrams total. 49 milligrams for the entire country. 2013, they're up to 250 milligrams total for the whole country. Let's take a break and talk about some of the successful alternatives here. I think one of the bright shining stars has been Hospice Uganda, which was started out of a Land Rover in the early 1990s. And I'll mention one part about them now and more later. But in 2000, with the help of a charitable foundation, they petitioned the Ministry of Health to produce morphine locally. And they were successful in this. Now, they weren't the first ones that they came to. Big Pharma was approached first, many times, and they were not interested. This was not a good business proposition. In Kerala, India, there's been similar strides. And because of the relative independence of this area of India, they've been able to make huge strides in a short period of time. Not only the local manufacturer of morphine, but on the education front, like we talked about, they've instituted a palliative care program that trains physicians there. And they've also, and this has been really instrumental, is they've changed some of the rules in licensing. I'll mention more about that in a second. But what do you think the cost to produce this oral morphine in an ideal setting, as both of these have nearly set up? So both of these have approached this price point. We want to talk about extreme affordability here. The cost to produce oral morphine on a per milligram basis is on the order of 1 cent per milligram. It's pretty cheap. So how much opioid is enough then? Well, if we look at the patients that we're talking about in palliative care, and about 80% of cancer patients, 50% of end-stage AIDS patients experience pain that in this country they would receive opioids for. A clinically accepted number in the last year of life for these patients has been 75 milligrams daily for 3 months. Now this is looking at across the board and averaging 75 milligrams daily for 3 months. That costs a little less than $70 total when we use the prior price point. Do you remember how much Burkina Faso said they need for this year? It's not going to quite cover it. Now, we don't really know the data on how much do we need to make a dent in acute pain. So hopefully some of the younger folks in this room can help me figure that out. Let's look at what's being done. So in Colombia, and this is an example of some other countries as well, they've changed the length of supply. Remember how Malawi, you could only get a 3-day supply. Well, it's been increased to 30 days from 10 in Colombia. And that makes for big strides. That means perhaps 3 trips to the physician over that 3-month period in the last year of life, as opposed to 9. In India, instead of 5 licenses, only 2 licenses are needed now in the pharmacies. And you can imagine the difficulty as one license expires, just as the next one is coming online, and then the next one expires. And this creates a perpetual cycle where nobody ever gets anything done. Hospice Uganda, as we mentioned earlier, is not only locally producing morphine, but they've extended their reach to Eastern Africa and are training specialists in palliative care in other countries, such as Ethiopia. They've also changed some of the laws within the country, and the Single Convention allows for this. Again, it's a broad outline. So many countries make it so that only physicians may prescribe opioids. Well, Uganda has made it such that nurse practitioners can take an advanced class, and then they're specially trained to prescribe opioids. This greatly increases the availability. And what's happened in this setting in Uganda is that this population that at one time was so difficult to manage and so cost ineffective has started to save money. And I would say even it lets the country as a whole focus on other issues, because you've taken out a group that suffers so much and you've provided them with the basics of healthcare. Pain Out is an interesting website that I would encourage you to look at. This is a collaborative group of anesthesiologists and surgeons from Europe. And what they have free and available online are procedure-specific, evidence-based guidelines. And it's just that simple. You can look up a colectomy, and they have, here's what I recommend preoperatively, intraoperatively, and postoperatively, with all of the references. So this helps with not only education, but this gives the power to anyone with an internet connection. The Essentials of Pain Management is a really interesting course that actually I've given in Ghana twice, once to practitioners and one to students. This was developed by Wayne Morris and Roger Gork, who are anesthesia pain physicians in Australia and New Zealand. And they've given this throughout the South Pacific and into parts of Africa. This is meant to take anybody in the country interested and teach them how to teach others the basics of treating pain. In one place it may be nurses, in another it may be physicians. So the way forward, I know this is manifold, but we have to look at ways that we can encourage country-specific action, because that's the only way, given the setup of the International Narcotics Control Board, that things can change. Wisconsin Pain Policy Fellowship is designed to create experts from these countries. And that's what helped the case of Colombia there. One practitioner went and does a 2-year fellowship and is back to help change things on the ground. I think we need to look at those around us. Surgery's role in alleviating pain is not only to sometimes create acute pain, but is certainly also to relieve it. And that's why we should look at partnerships with them and palliative care. Palliative surgery and enlarging our scope here, I think, establishes the interdependence that is the reality of it. We should help ensure access without diversion through education and promoting clinically relevant policy. And again, the country-specific approach is the only way forward. I want to finish with giving you a charge that as you're working with your colleagues in other countries, ask them what they're doing and what their hospital's doing to ensure pain management. That's how I got started on this path, so I'll warn you, you may not like where you end up, or it may be interesting where you end up. But engage them and ask them, because once we leave, these patients are still experiencing pain. And I'm sure that many of you had similar circumstances or experiences that I have, where in Ghana, our patients seem amazingly stoic in the face of extreme injury and pain. But I would say that in a world without the possibility of pain medication, we should not mistake their silence for a lack of suffering. Thank you.